Good afternoon, everyone. Can you all hear me okay in the back? Okay, great. Sorry about my voice. This is my third talk today, so I'm starting to lose it, and I apologize. But I'm so excited to be here. I think what NephCure does every year with this patient summit is absolutely incredible, and it's such a great chance to meet all of you. I know it's taking time away from your weekend and your Friday to be here, so thank you so much for joining. I'll tell you a little bit about myself before we get started. So my name is Shika Wadhwani. I'm a nephrologist and a glomerular specialist from Chicago. I work at Northwestern University in the medical school and see patients there. I actually got into nephrology because I saw a patient with autoimmune disease in her 20s on dialysis during my training, and that's partly why I decided this was the right field for me. I didn't want people ending up on dialysis, especially young people, but ideally no people, and that's what really drove me to specialize in glomerular diseases. So after my general nephrology training, and I also got a master's in clinical research, I did something unique. I did another fellowship in glomerular diseases at The Ohio State University, and that's where I was really exposed to being involved in clinical trials. Interestingly, my first job out of college was working on a clinical trial as a research coordinator, which a lot of people don't know. And I knew before I wanted to be a nephrologist that I wanted to run trials and help get new therapies to patients. So after my kidney training and my additional year focusing specifically on glomerular diseases, that's when I ended up back in Chicago, which is my hometown, starting a glomerular disease program at Northwestern. And there I really have a clinic focused on patients with these autoimmune inflammatory kidney diseases. I run the clinical trials there. I also do some teaching, and I also started a glomerular disease fellowship program. So IgAN is very near and dear to my heart, and the reason for that is my very first trial as what we call site principal investigator was on a trial that I'll mention today, the NefIgArd trial, that led to the first ever FDA-approved drug in IgA nephropathy. And now there are more trials than I can even run by myself in one place. So it's a really exciting time for patients with this condition. I don't wish glomerular disease upon anyone, but if you're going to have IgA nephropathy, now's the time, because we finally have things that we can do about it, which back when I started my training, if I was giving this talk, we'd be done in like 3 slides because there was really nothing to talk about. There wasn't much available. And now, as you'll see, I can't even scratch the surface in the time that we have allotted on what the new therapies are and where we're headed. So I really would love for this to be an interactive session. Like I said, I've been talking all day. I'd love to hear from some of you. So please feel free to ask questions. Either you can raise your hand as I go if you have a fresh question that you want to make sure you get answered, or we'll make sure that there's plenty of time at the end as well. So with that, I am going to get started and make sure that I do with my water bottle in case I start coughing. Okay, hopefully we won't cough. So the new landscape for IgA nephropathy patients. So my outline today, we're going to start with briefly discussing what IgA nephropathy is, or IgAN as a lot of people know it. We'll talk about how you assess risk of disease progression. We'll briefly discuss the current or the traditional treatment paradigm, and then hopefully spend a lot of our time talking about the new therapies approved to treat IgA nephropathy. And then I'll end with just mentioning in brief some of the new clinical trials that are ongoing for the treatment of patients with IgA nephropathy. And who knows, if I come back in a couple years, I'll have more to talk about. That's the goal. So you may have seen this slide before, looking at rare protein spilling kidney diseases or glomerular diseases. In case you haven't already been given the basics on glomerular diseases, the glomeruli are really the filtering units within the kidney. So we have, I don't know if this is showing up here, but does my arrow show up? Okay, good. We'll use the arrow. We'll forget about the laser pointer. So the glomerulus is the filtering unit in the kidney, and I think the most exciting part of the kidney, because that's where all the action is. All those tubules, they're just straight. They're not very exciting. So glomerular diseases are these rare diseases that really lead to some abnormality within this filtering unit. And generally, what happens is there's some kind of an injury and it leads to protein or blood or both ending up in the urine, which is not where it's supposed to be. All your protein and blood is supposed to stay within your body. I often use the analogy to my patients of a coffee filter. So think about how sometimes you make a cup of coffee at home and you look at the bottom of your cup and there's coffee grounds and you're just like, ugh. Great. I need to change my coffee filter out. Hopefully I don't need a whole new machine. So as a nephrologist, if we detect protein or blood in a cup of urine that you very nicely pee for us, that's the same thing as coffee grounds. It means you have a leaky filter, and that filter is this glomerulus within the kidney. So a lot of different things can cause damage to the glomerulus, but specifically for patients with rare kidney diseases, these are often autoimmune conditions, inflammatory conditions, sometimes genetic conditions, and then sometimes we just don't know why, or we don't understand the disease completely, and that's called idiopathic. So just to give you, I'm just going to use this, a really quick overview. So this is the kidney glomerulus. Blood comes into the kidney filters out all the waste products that we want to get rid of, and those end up in the urine. But anything that we want to keep inside after the kidney cleans it, like blood, protein, etc., is supposed to go back out, in and out, and go back into the body circulation. But when there's damage to some particular part of the glomerulus, what ends up happening is in the urine you can start detecting protein or blood, and that to us is a sign of disease. So let's talk about IgA nephropathy specifically. So IgA nephropathy, also previously known as Berger's disease, falls under this category of rare kidney diseases or glomerular diseases. It's actually the most common glomerular disease worldwide. So it is a rare kidney disease, but amongst the rare kidney diseases, it's the most common worldwide. In the United States, about 2.5 per 100,000 patients have IgA nephropathy, but that's probably a gross underestimation because not everyone gets a kidney biopsy. And one of the things I talked about this morning, if any of you were at the talk with Dr. Smoyer, who's a pediatric nephrologist, and I, one of the things I mentioned is that patients often don't get their urine tested unless something's wrong. And it's a huge problem and something that I think we really need to focus on in order to get patients diagnosed earlier. So unless you're going into your doctor's office complaining about, urinary symptoms or pain or burning, a lot of times no one's telling you, hey, we should check an annual urine. And even when you do get a urine checked, I can't tell you how many patients come to me and they were like, wait, but there's always blood in my urine and I was told it was no big deal or it was just a UTI. They kept giving me antibiotics. And I was like, oh boy, that probably, was not actually a UTI. Sometimes in women, they're just told, well, that you were probably on your menses, or maybe it was just menstrual blood. And sometimes in other patients, they're told, oh, well, maybe you're spilling blood in your urine because you have a kidney stone. And so they'll send you to go see a urologist, or get an ultrasound or a CAT scan. I'm seeing a lot of nodding here because it sounds like people have experienced this. And what that leads to is delays getting to a nephrologist. And by the time you're diagnosed, your disease has already progressed farther than had we caught it earlier. And so, as you know, it presents with blood and protein spilling into the urine. What it doesn't present with, what I don't have here, is a lot of swelling in the legs, swelling in the face, like some of the other glomerular diseases that are rare kidney diseases that NephCure also focuses on. So what does that mean? Well, it means that if you're not having systemic symptoms, meaning you're not walking in with like a really bad headache or chest pain or shortness of breath or swelling, people may not know anything's wrong with you, right? Your kidneys don't always cause pain when they're not working well. In fact, most of the time they cause no pain and people have no idea that they have kidney issues. So, that's why IgA nephropathy is just so difficult to diagnose and why it takes quite a bit of time sometimes for patients to arrive at the diagnosis. And unfortunately, a lot of times it takes having what we call an elevated serum creatinine or a low GFR for a doctor to notice that something's wrong. And that assumes that you had a blood test done for some reason. A lot of young people aren't even having blood tests done. They're not seeing doctors annually. So, IgA nephropathy, it can occur in children, can also occur in adults. The majority of patients are diagnosed somewhere between their 20s and 40s, but that doesn't mean that's when the disease started, right? The disease could have started years before. This is just the time where someone sent you to a nephrologist and you got a kidney biopsy and you arrived at that diagnosis. So, talking about diagnosis, how do we diagnose IgA nephropathy? Well, there are many, many kidney diseases that cause you to spill protein and blood into the urine. So how are you going to know you have IgA nephropathy? Well, knowing you spill protein or blood is not enough. Now, some patients, the first time they go see a doctor is because they saw blood in the urine. One day they woke up and they peed blood, which is terrifying. And it can occur in the setting of an infection oftentimes. Those patients probably ended up seeing a doctor sooner, but the vast majority of patients with IgA nephropathy are never going to actually see blood in the toilet. They're only going to know that there was blood because they peed into a cup and it was looked at under a microscope and that microscopic hematuria was discovered. So what this means is that because there's, so many other things it could be, you have to get a kidney biopsy. Unfortunately, as of today in 2024, we don't have a biomarker that we can just check in your blood or in your urine to say, oh, you have IgA nephropathy. I know because this particular marker 100% correlates and every person with IgA nephropathy has it. So we're not there yet, unfortunately, and that's why people have to get a kidney biopsy, which some of you or your loved ones may have had. And as you can see, it's an invasive procedure. Some people do end up staying the night, but it's fortunately not open surgery or anything, and some people do end up getting a few biopsies during their lifetime. So now that you have a diagnosis, everybody wants to know, well, how did this happen to me? How did IgA nephropathy develop? And what we know is that IgA nephropathy, there are certain individuals that are susceptible. That may be because of genetic factors. It may be because of alterations in the gut microbiome. We definitely know the mucosal immune system is involved, and that's why a lot of patients that have a diagnosis of IgA nephropathy, like the ones I mentioned that pee blood, it's around the setting of, say, an upper respiratory infection. I have multiple patients who, when they had COVID or had RSV or influenza, they called and they said, I'm peeing blood, and I think my IgA nephropathy is acting up again. So infections, as I mentioned, can also be a trigger, maybe something related to food antigens. That's still an active area of research. But I have patients that tell me that they feel better when they're on a gluten-free diet, so maybe there's something to this. But ultimately, there's some reason that people are predisposed and they have the right genetic background to predispose them to IgA nephropathy. And then something comes along and triggers it, whether that's an infection or something else, and it leads to this cascade of events. And you'll hear about, I'm going to show you in the next slide, what we call the 4-hit hypothesis. Do not worry, there is not a quiz at the end. You are not going to need to know the different parts. I don't know that my fellows and residents could tell me what the 4 hits are, to be honest. But just to kind of point out that there's a lot that's happening, and ultimately this is an autoimmune disease. So your body is producing these, what we call galactose deficient IgA, and your body reacts to that by forming antibodies. Those together form what we call immune complexes, which is hit 3, and then those immune complexes go and deposit in the kidney, and that's how you get IgA nephropathy. I think this next slide is a little bit easier to see what I mean. So here's hit 1. You have increased production and circulation of the galactose deficient IgA1, which is a type of immunoglobulin, and in the right person, now normal healthy people can also have this galactose deficient IgA1, but there's something about patients with IgAN where their body then starts producing antibodies. So it's like your body's like, whoa, there's an invader, something's not right here, I want to attack it, and it forms these autoantibodies to the galactose deficient IgA1. Those combine, so you have the red, the yellow, they combine into these little complexes. They look so cute, but they're terrible. So these immune complexes are pathogenic, and they actually go into the kidney and they deposit in a specific part of the glomerulus called the mesangium. So this is what we know at this moment about IgA nephropathy. There's still a lot we don't know. But what's helpful about this is you could start to think about, well, how can I treat this disease? And I think for a long time, we were just focusing on maybe targeting HIT4. We already know that the deposits are there, and maybe once we know that and we have the diagnosis, we can try to prevent all the different things that happen once the immune complexes are deposited, like scarring, inflammation, and we want to try to prevent dialysis or kidney transplant. But what if we could do something up front? What if we could actually decrease the levels of galactose-deficient IgA1? Or what if we could prevent the formulation of these autoantibodies, or perhaps prevent the immune complexes from forming? Then we would never get to the downstream pathways. And I think a lot of the current sort of research on the molecules that are in development are looking at how we can target different aspects of the disease, because maybe there's not a one-size-fits-all answer, and maybe what we really need is targeting multiple areas. So a big question I hear from my patients when they're diagnosed with IgAN is, are my kidneys going to fail? And, you know, when I was in my training, I was told, well, there's this 1/3 rule. A third of patients are going to have no problems. Their kidney disease is never going to progress. A third are going to slowly progress. And then a third are going to progress very rapidly. And we just don't really know which group people are going to be in. Fortunately, 10 years later, we know a lot more. And this is some data out of the UK. So this is in the United Kingdom. And what they showed is if you look at time here, and you look at survival from kidney failure, and these different color curves are based on how much protein you have spilling in the urine. So the yellow is people that have a lot of protein spilling over 1.5 grams to 2 grams. And then the pink is less than 0.5 gram per day. And so what you can see is the more protein you spill, the more likely you're going to end up in kidney failure. And that's why as nephrologists, we really focus on lowering the protein in your urine as much as possible. What this also told us, though, is previously, I'm gonna go back. What did I do? Okay, I'm not, you guys, Max are where it's at. So what, I'm not gonna touch this. So what this tells you is even patients who have really low grade protein that we previously thought their disease was benign, 20% of people with 0.5 gram per day of protein or less are in their lifetime going to end up on dialysis. And in this cohort, the average age of kidney failure was 48. Like, I don't know about you all, but I'm not too far from that, and I really would not want to be on dialysis or need a kidney transplant in my 40s. So I think we as a community need to do better, and I think that patients need to know this so that they can advocate for themselves as well. What can you do, doctor, to help lower my protein levels in the urine and protect my kidneys? The other thing that's important is taking a look at your GFR decline. So here what you see is what we call a heat map. You can see this is annual eGFR decline, and then here on the x-axis is your age group, right? And the redder, the worse. So let's say that you are in the 30 to 40 age group. What this is showing you is that if you have a 3 ml per minute, here's the 3 ml per minute decline in your kidney function each year, you have 100% likelihood of some point in your lifetime developing kidney failure. That to me is tragic. There's no reason why people in their 30s and 40s should end up on dialysis or need a kidney transplant. I actually just had a patient who was 33 need a kidney transplant from IgAN, and it was really, really difficult. So what we need to do is try to figure out how can we get patients on the right therapies or multiple therapies to reduce their GFR decline. So if that same 30 to 40-year-old had only 1 ml per minute decline per year, we're talking that risk is cut by 2/3 almost. And if we can ideally have no GFR decline at all, we could reduce their risk to 2%, which would be amazing. So this is just not to scare you, but just to, hopefully empower you to have conversations with your physicians and try to take an active role in your disease so that you know what the numbers mean and you're pushing to try to preserve your kidney function. So we have a diagnosis, you know about the risk factors, you know that spilling a lot of protein is going to lead to increased risk, as is GFR decline. So how are we going to treat this disease? Well, initial steps are always for almost any proteinuric kidney disease starting a RAS inhibitor, which you may have heard an ACE inhibitor or an ARB, angiotensin receptor blocker, common names that you may have heard of, lisinopril, enalapril, losartan, irbesartan, valsartan, etc. And the goal of those medications is to really lower the protein spilling in your urine. I tell my patients these drugs should just be in the water for patients with kidney disease because they're 3 for 1. They lower protein in the urine, they lower blood pressure, and long-term they prevent scarring. So with the RAS inhibitor, you can get 3 benefits all in one drug. And a lot of people, when they go to their pharmacist will say, oh, do you have high blood pressure? You're starting a blood pressure medicine. But in reality, what we're specifically using these types of drugs for is because they lower protein in the urine, which a lot of anti-blood pressure, antihypertensive medications do not do that. So that's specifically why you just need to be on these ACE inhibitors or ARBs. Now, managing blood pressure is also important. The blood pressure goals in patients with IgA nephropathy is lower than what may be the goal for general patients with high blood pressure. So ideally, you want to try to get your blood pressure to like 120/80 or less without getting dizzy. If you're running in the 140s, 150s, that is way too high. And if the bottom numbers are running in the 90s, that's way too high as well. And that's associated with risks of not just kidney disease progression, but also cardiovascular disease, which I mention here at the bottom as well. Other things, people always ask me, well, what can I do that doesn't involve a medication? And lifestyle changes are important. So that can involve dietary changes. Specifically, the most important one is reducing your salt intake to less than 2,000 milligrams a day. That's not easy to do because a lot of foods have a lot of salt in them and they don't even taste salty. So you have to start looking at the back of, package labels. I didn't know bread, for example, had salt in it and it doesn't even taste salty. And then exercise, of course, like all of the American Heart Association, everyone says you should try to exercise at least 3 to 5 times a week for 30 minutes. That's easier said than done, but I think in general, for patients that are overweight, losing weight is always going to help your kidney disease and also lower your cardiovascular risk. And I bring this up because a lot of patients don't know that having a kidney disease is like a 2-in-1 gift. And I mean that in a very sort of sarcastic way because kidney disease is a risk factor for cardiovascular disease. And so we cannot ignore the fact that most patients with kidney disease, if they have it for long enough, are going to be at risk of something happening to their heart. So it's good to just start addressing those issues now, whether that's cholesterol, the blood pressure goes into it. Some patients are actually on fish oil pills for IgA nephropathy. It's controversial whether or not it actually provides benefit, but the way I figure, if you can handle the fish oil pills and swallow them, it's probably not going to hurt. It might also help your heart. So I definitely think it's worth it. But, if you are taking a bunch of pills and you got to drop one, that's the one that, I would definitely take the ACE inhibitor or the ARB over the fish oil pill. That's not even a question. So what if your numbers aren't getting better? What if you did all of those things for, 3 months, and we call that optimizing supportive care, but you're still spilling a lot of protein? Well, then, the guidelines suggest actually, here we go with my Mac usage, or my PC usage, consider enrolling in a clinical trial. So part of the reason that we have new therapies that I get to talk to you about today is because people like you with IgA nephropathy or people or loved ones of yours enrolled in clinical trials, and that's how we were able to get enough people and we're able to study the safety of these medications so that they're now on the market and we can offer them to you. So that is still, I think, a really, really good idea. And then beyond that, you need to risk stratify. So where is your kidney function right now? If it's less than 30 mLs per minute, so that would be CKD stage 4 or less, so CKD 4 or 5, the recommendation is to really focus on maximal supportive care. This is based on 2021 guidelines, and I'm going to say separately that I personally have given people medications even when they're have a GFR less than 30. So these are a little bit outdated and they're going to be revised, but just because you have a GFR of 25 doesn't mean you have to put your hands up in the air and there's nothing you can do. But I'm just showing you what the guidelines say as they stand right now. If you have more than 30% kidney function, which I certainly hope you do, then the recommendation is to risk stratify, look at all these different factors, the age, the weight, whether there's infections that like TB or hepatitis, and then weigh the risks and benefits of giving glucocorticoids. So this is based on older data that we've had for years and years and years. And I mentioned to you when I was in my training for IgA nephropathy, this is it. This is all I had to talk to patients about. We'd be done in a couple of minutes because I'd be like, well, your options are RAS inhibitors or your options are steroids. And when some of the older data came out, patients who had more than a gram per day of proteinuria, despite being on the RAS inhibitors, they were getting prednisone. So this is a slide I took from a talk I gave 10 years ago. And, being in Chicago, we love Oprah. And she, would probably tell you, well, if you have over a gram of proteinuria, you get prednisone, everybody gets prednisone. But my patients are like, really? Is there nothing else I can do? Because look at all these potential side effects of prednisone. You can gain weight, you can have a moon facies, so your face can be enlarged, you can have swelling in your legs and other places, mood swings, easy bruising, poor sleep, high blood sugar, and some patients who are pre-diabetic even develop diabetes while they're on prednisone. Your infection risk increases, and then you can develop problems long-term if you're on prednisone for a long time with your bones and increased fracture risk, as well as eye issues like glaucoma or cataracts. So you can see that a lot of patients are not particularly excited about being on prednisone. Now the good news is we have some new things to talk about. And I was really excited because last year in 2023, this was released, the top 10 nephrology stories. Yes, nephrologists are nerds. But the number one story was IgA nephropathy now with new drugs. So it's not just for glomerular disease specialists, but for kidney specialists all over the world. We're finally having new therapies to talk about, and I'm glad that, this is getting a lot of attention. So what are some of the new and emerging treatments? Well, there's on the left side, I have a list of drugs that are now approved by the FDA, and we're going to go into some detail in each of those. And then on the right side, I have drugs that are currently in phase 3 clinical trials. And as I mentioned, maybe in a year or 2 or 3, if I come back, I can tell you more about some of those drugs, and they'll move from the right side to the left side, which is the goal. I would love for there to be, way more drugs approved than there are in trials. But I am really excited that we have trials ongoing. And, one of the things that people always ask me is like, well, why did we never have FDA-approved therapies before for this disease? And the reason is because the older studies, they lasted like 10 years, and patients had to stay in a study for 10 years before they ever knew which group they were in. And why was that? Because patients were, these are rare kidney diseases. And so rare kidney diseases, especially ones that don't progress rapidly, you need a lot of patients and you need to follow them for a really long time before they have an event. And what's that event? That event traditionally was kidney failure, so need for dialysis or need for transplant. And that might take years to develop, but that doesn't mean that damage isn't happening in the meantime. So fortunately, a group of experts got together and they started working with the FDA, and they decided together, based on looking at a lot of data from trials, that actually proteinuria is what we call a very good surrogate endpoint or surrogate marker. And based on these discussions that happened and looking at all this data, the FDA said, you know what, I don't think you need to have 10-year trials anymore. You can do shorter trials of, say, 2 years, and you can look at the degree of protein spilling in the urine at about 9 months, but continue the trial to at least 2 years where you look at the kidney function or that estimated GFR. And if the therapy is safe and it's doing better than the placebo or comparator arm, we will consider approving these drugs for patients, which was really exciting because that's how we got industry, pharmaceutical companies interested in IgA nephropathy, because they didn't have to do 10-year trials, which are really expensive. And it also got patients more interested because they didn't need to be in a trial for 10 years and find out, oh, maybe they were in the placebo arm. They were just in a trial for about 2 years. And one of the things that's also unique and something that we're really working on in newer clinical trial design is designing the trial so after those 2 years, there's what we call an open label extension. And what that means is regardless of whether you're in the placebo group or the group that got the drug, because you don't know which one, after the end of the study, everyone is eligible to be on the drug, and that's what's called open label extension. So it also makes it worthwhile for the patients to be in these studies because they know they're going to have access to a drug that no one else has outside of the trial. So that's kind of how we got to a place where we have any drugs available in this side of the column, and this is very, very recent. So 5 years ago, there were no drugs that were approved. This is all within the last, I would say, 3 years, maybe 4 years. Okay, so we're going to talk about sparsentan, dapagliflozin, and pagliflozin, which are SGLT2 inhibitors, and Nefecon, which is targeted release budesonide. The ones that are in trials that I'm not going to go over, but just to have for you guys to keep an eye out, when you're like bored from looking through Instagram and TikTok and you want to know what's going on in IgA nephropathy, you could always Google one of these and see what's going on. Some of these trials have some emerging data that's actually being published or being released just this year. Some of the data has already come out and some of it's going to be coming out soon. So, it's very exciting to see where we're going to be not too long from now. Okay, so let's talk about sparsentan first. So sparsentan is unique because it has a dual mechanism of action. On this slide, I forgot to say that it's what we called a DERA, or a DEARA. A DERA is a dual endothelin antagonist and a angiotensin receptor antagonist. So that's a mouthful. I could barely say it myself. But what that means is that it's targeting 2 different pathways at once. It's not 2 different drugs that are combined in one. It's just one drug, but it happens to target 2 different pathways. So what's really nice about this is that if you look over here, let me use my arrow. So here's sparsentan, and the 2 pathways it targets are the RAS inhibitor pathway, or angiotensin 2, and then the endothelin pathway. And you don't need to, really focus on the details here, but what you can see is that angiotensin 2 and endothelin 1 are not our friends. They cause a lot of problems in the kidneys. They cause endothelial dysfunction. They cause those mesangial cells that I showed you where the IgA deposits to proliferate. They cause extracellular matrix production, glomerulosclerosis, which basically means scarring within the kidney, and then they cause a ton of problems to the podocytes, which you probably heard about in some of your earlier talks, but there's a lot of problems that they cause in addition to inflammation and fibrosis, which is scarring. So there's a lot of interest in blocking these 2 things, endothelin and angiotensin, because maybe if we can block these sort of deleterious effects, we can actually protect the kidney from having further injury. So your traditional RAS inhibitor right here, which I told you should be in the water, your ACE inhibitors, your angiotensin receptor blockers, they're going to target all of this. But they don't touch the endothelin aspect, right? And so why sparsentan was being studied in this disease is because it targets both pathways, and people were curious, well, if I target both pathways instead of one pathway, will these patients end up doing better? And I'll show you the data. So in general, in terms of, remember those 4 hits I showed you? In general, it's thought that sparsentan probably does act at hit 4, which is to prevent further kidney injury. It has these anti-inflammatory properties, also anti-fibrotic properties or anti-scar. And the really nice thing for my patients is that it's not immunosuppressive. It's not suppressing your immune system. The other nice thing about it is it's just one pill once a day. And it's taken instead of your ACE inhibitor or your ARB. So let's say you're on lisinopril right now or you're on valsartan right now. Well, because this is a dual mechanism, you actually shouldn't take it with that because that would be overdosing it. So you're actually going to just take this instead of whatever ACE inhibitor or ARB you're on currently, if this is deemed to be a good choice for you. So I mentioned that this drug was studied in a clinical trial, and this is the clinical trial I'm talking about. It's called the PROTECT Phase 3 clinical trial. It was double-blind, meaning that patients didn't know which drug they were getting, and physicians didn't know which drug they were getting. It was international. It had over 400 patients, and they studied patients with high-risk IgAN, meaning it wasn't just given to every patient with IgAN. You had to have a lot of proteinuria to go into the study. They compared sparsentan to irbesartan being a regular RAS inhibitor, and they looked at how much protein patients were spilling at 9 months. That was called the primary endpoint. And then they also looked at eGFR, or their kidney function, at 2 years, and that was the secondary endpoint. And the reason that they designed it this way, as I mentioned earlier, is this is what the FDA is now requiring. But the nice news is it's not a 10-year trial, it was a 2-year trial. So I'm trying to avoid showing you guys too many graphs, but some people are visual learners, so I'm going to show you a few, okay? So what I want to point out here is the blue is irbesartan and the red is sparsentan, okay? And what we're measuring here is protein levels. And here we have the number of weeks of the study going all the way out to week 110, which was the 2-year mark. So what you see is that the irbesartan group, which would be your regular RAS inhibitor, these patients did have some reduction in protein when they went into the trial. Why is that? Because, well, they're in a trial, someone's monitoring them very closely, they're being given the drug, they don't have to go get it from the pharmacy. In general, patients in clinical trials are probably doing a little bit better than the average patient. So these patients did have further decline in their protein once they were in the trial. But then if you look at sparsentan, look at their protein decline. Within 4 weeks even, these patients had, 40% decline compared to the irbesartan group, and that was really sustained throughout the course of the study. So it wasn't just that the protein went down and then it went back up. As long as you were on the drug, the protein levels stayed low. So this is what led to the FDA giving sparsentan. Oh, here, I forgot to show you that. This is the primary efficacy endpoint at 36 weeks or 9 months. So based on this, the FDA gave accelerated approval to sparsentan, meaning that it was available for physicians to get to their patients because it was safe, and at 36 weeks, it seemed to be doing better than irbesartan. Following that, the study continued, and they looked at the GFR. So now here we have GFR, and again, we have number of weeks all the way out to 110, at which time they stopped the drug, and they followed patients for an additional 4 weeks. And what you see here is that higher GFR is better, right? eGFR means kidney function. You want your GFR to be as high as possible. So patients who were on sparsentan throughout the study, ended up with higher GFR compared to patients in the irbesartan group, and that was all the way out until the end of the study. So currently, sparsentan is being considered by the FDA for full approval, and it'll remain to be seen in a couple of months whether they are fully FDA approved, but it's already available for patients to use based on the data I just showed you before. Okay, so it's important that medications work. It's also important that they're safe and that the risk-benefit ratio is in favor of using the drug. So here I have from the publication all of the different side effects between sparsentan and irbesartan. It just kind of shows you the percentages. Obviously, the study was going on during COVID, so a lot of people had COVID. Doesn't mean it was because of the drugs. It was just you have to report everything. But the take-home message here is that the drug was well tolerated and safe. Some patients did get dizzy with it. and get low blood pressure. Keep in mind, this is a 2-for-1 molecule, right? So some patients were getting lower blood pressures, but also some of these patients were on other medications to lower their blood pressure. And if they were able to be on sparsentan, sometimes you can stop taking one of your other blood pressure medicines, which again, my patients always like if I take away medicine as opposed to add more. Do you have a question? No. Okay. Okay, no. I just want to make sure I didn't miss it. And the one thing about sparsentan to know is here in the United States, the FDA currently has what we call a REMS program, and that's a safety monitoring program, essentially, that patients and their physicians need to enroll in so you can have access to the drug. We know that the class of medications that sparsentan is, the endothelin receptor antagonist, does cause damage to fetus. So women are not allowed to get pregnant while they're on this drug, and they actually need monthly pregnancy tests while they're on the therapy to make sure they don't get pregnant. Currently, and that's something that's going to stay with this drug forever, and that's just for your own safety if you're a woman who's on this. The other current REMS program that they have is a monthly liver enzyme blood test for the first year, and then every 3 months or 4 times a year afterwards. This is because older drugs that are like sparsentan, not sparsentan itself, but other endothelin receptor antagonists, they had seen some liver signals in other studies looking at other diseases, not even IgA nephropathy. And so the FDA was just being very, very conservative because they approved it after 9 months of data. They were like, let's put this liver monitoring sort of stipulation on patients for now. Whether this is still going to be there once they have the full approval, we don't know. We'll have to see what the FDA thinks. The important thing to know is if you look all the way at the bottom here, oh, it's kind of getting cut off. But the number of patients who had liver enzyme elevation was 5 patients in sparsentan and 7 patients in irbesartan. So actually the comparator had more liver issues than the sparsentan group, and none of these patients actually had liver injury or hepatotoxicity. It was just a minor elevation in the liver enzyme. So I think for the most part, the consensus is this is very safe. If you look through, what you don't see is all the steroid side effects because it's not a steroid. So patients are happy that they could take this potentially instead of steroids and instead of their RAS inhibitor. Okay, so there's another class of drugs that is now being used in IgA nephropathy, and those are called SGLT2 inhibitors. So you may have seen some of these commercials on TV for medications like dapagliflozin or empagliflozin. These were actually drugs that were created for diabetics originally. They were being used for diabetes, and then people realized they actually have multiple benefits for the kidney and the heart. And these also act on HIT4, so to prevent kidney injury. There's a trial that I'll show you in which they studied patients with chronic kidney disease, and a couple hundred of those patients had IgA nephropathy, and they separately looked at those patients. And what they found was that patients who were on dapagliflozin compared to placebo seemed to do better in terms of their kidneys. So now dapagliflozin is being used in patients with IgA nephropathy as well. Now, how does this work? Well, essentially, SGLT2 blocks sugar or glucose reabsorption, and so if you inhibit SGLT2, which is what this drug does, the glucose can actually go back into or spill into the urine, and they think this leads to some hemodynamic effects that are helpful for the kidney. There's probably a lot of other effects from SGLT2 inhibitors that we don't completely understand, whether those are anti-fibrotic, anti-inflammatory. We still need to understand more about it. But overall, this drug seems to be doing really well for patients with chronic kidney disease. And that's the thing I want to point out here, is that the IgAN patients that were studied in this dapagliflozin study, they were patients that already had some degree of chronic kidney disease. And we don't know if you have a GFR of 100, let's say, or 90. We don't totally know the benefit. People think it probably is still beneficial, but we just don't have that kind of data as of yet. Now, in terms of what the drug is like, it's one pill taken once a day. So again, it's nice, it's a pill, it's not an infusion or an injection. This would be taken in addition to the ACE inhibitor or the ARB you're already on. So here's that trial I mentioned, the DAPA-CKD trial, and without going into all the details, they had 270 patients in the study who had IgA nephropathy. Some of those patients also had diabetes, but the majority did not. And what they looked at was a composite primary endpoint, which was kidney failure, cardiovascular death, kidney death, or a 50% decline in your kidney function. And over the period of the study here, shown up to 32 months, you can see that more patients who were on placebo hit one of those bad outcomes compared to patients who were on dapagliflozin. And this is just another way of looking at it. This is called a forest plot. And ultimately what you see here is patients who had IgA nephropathy, no matter how you looked at it, patients that were getting dapagliflozin compared to placebo, they did better. So if you blinded people to either dapagliflozin or a placebo pill, and you studied these people over time, the patients on dapagliflozin had less kidney failure or progression to chronic kidney disease. So here's, if you're the visual person I mentioned, here we're looking at eGFR, and you can see that, these are pretty comparable in terms of placebo versus dapagliflozin. But if you look at the proteinuria, the patients with dapagliflozin had definitely less protein spilling in the urine compared to the patients that got placebo. Okay, so the third medication I want to talk to you all about is Nefecon, or targeted release budesonide. So this was actually the first FDA-approved drug for IgA nephropathy, and this one has gotten the furthest in the process. It is now fully approved for the treatment of IgA nephropathy. So how did this drug come about? Well, budesonide is something that we've known about for a while. It's been used in GI patients. There's an inhaled form that's used for some patients with respiratory issues. But ultimately, it is a steroid, and it's actually a very potent steroid. But it was formulated in a way that it's pH dependent and has delayed release. And the reason that's important is because there's a part of the gut in the small bowel where there's a lot of cells called the Peyer's patches, and those Peyer's patches are where there's a high amount of galactose-deficient IgA1. Remember, all the way back to hit 1 of increased production of galactose-deficient IgA1. So here's those Peyer's patches that I mentioned, and they're producing all this galactose-deficient IgA1, and someone thought, well, what if I can give steroids locally right where that galactose-deficient IgA is being produced? Maybe I could lower the chances of these people developing immune complexes and going through that whole process. So this drug was developed to, again, act locally. The entire sort of pathophysiology of how it really targets the Peyer's patches is still being sort of elucidated. But it was studied in a clinical trial, which I'll show you some of that data, and obviously the data was positive, or it wouldn't have been approved as a therapy. In terms of what it means for patients, it's 4 pills taken once daily. Again, it's pills, not injections, which is nice. And this should be taken in addition to your ACE inhibitor or ARB, which is sort of your foundational therapy. The big thing about Nefecon that got people excited is it's thought that because it acts locally and due to some of the other what we call pharmacodynamic or effects, it perhaps will not give you the same side effects as if you were taking prednisone. Now, that being said, it's not like a zero side effects. Some patients do get steroid side effects, but it wasn't compared head-to-head with prednisone. It was compared head-to-head with placebo. So the trial I was referring to is the NefIgArd phase 3 clinical trial. Like the PROTECT trial, it was double-blind and international, meaning patients and doctors didn't know whether you were on Nefecon or whether you were on a placebo. It enrolled patients who were at high risk of disease progression. And again, they looked at proteinuria at 9 months, and they looked at GFR, or kidney function, at 2 years. And again, for my people that like graphs, here's Nefecon in blue and placebo in red. We're looking at the amount of protein spilling and the change from baseline over a course of 24 months. The important thing to know here is that patients only got 9 months of the drug. So you can see that here's Nefecon. They're on the 9 months of the drug. Their protein is lower compared to placebo, right? After that, they're taken off the drug and they're just followed. So after the 9 months, there's an additional 3 months on average where patients continue to have more decline in protein. And then there is a little bit of an uptick after that once they've been off of the drug for some period of time. But overall, when you compare it to placebo, there was still a significant difference of 30% between the two groups. After this, there was an open label extension phase, and I forgot to mention in the PROTECT trial, there's also an open label extension. So both of these studies, everyone in the study is going to be potentially eligible to get the study drug and see how they do long term. For this study, the company actually just announced that they had some positive results for the open label. We have yet to see what that data is. It's going to be presented at a meeting in Europe later this month, actually. So like I said, we'll know more. In terms of GFR, so here we have GFR, kidney function, and again, this is the 9 months that people were on treatment, and this is the time that they were just being followed without treatment. And what you can see is the placebo arm continues to lose GFR, right? So if you're on nothing but an ACE inhibitor or an ARB, theoretically, this could be your GFR trajectory. Patients who were on Nefecon, seem to do better. The slopes of the lines look a little bit parallel, but at the end of the study, patients who were on Nefecon had a -6 ml per minute decline versus those who were on placebo had a -12 ml per minute decline. So obviously, we're not where we want to be. You remember that heat map that I showed you at the beginning where we want to try to get people to less than 1 ml per minute per year? We still have a way to go, but at least we're starting to develop drugs that can attenuate that decline in GFR. And keep in mind, this is not all patients with IgA nephropathy. These are the patients who are deemed higher risk. That's why they're enrolled in clinical trials in the first place. So what about safety? Well, overall, Nefecon was well tolerated. Here we have Nefecon versus placebo and some of the side effects that were seen in over 5% of patients. I'm sorry, this is a little bit small also. But one of the common things that was seen was swelling. There was also a little bit more high blood pressure in these patients. The risk of infections, though, was pretty similar, 9% versus 10%, placebo versus Nefecon. The same with, here we have upper respiratory infections, 5% in each group. So I think that was reassuring when you're thinking about something that is a potentially locally acting steroid. You always worry that steroids can suppress the immune system and cause increased risk of infection. So it doesn't mean that there's zero risk, but perhaps it's less than if you were on prednisone at high doses for a long time. So, there were some patients who developed traditional steroid side effects like acne and other effects. But again, this was not compared head-to-head with prednisone. It was just compared to placebo. So something to think about. And then I think this is my last or second to last slide. I just want to show you kind of where we are and where we're headed. So these are some of the, hopefully I have all of them. I don't know if I'm missing anything, but these are the phase 3 clinical trials currently in IgA nephropathy. We went over NefIgArd, which is the budesonide. We talked about PROTECT, which is sparsentan. And there's a bunch of other trials that are currently in patients are enrolled and are being followed. So there's the Visionary trial, which is cipralelimab. There's the Origin trial with atacicept. There's Applause with iptacopan. And then there's Artemis, which is narsolimumab, which actually that study has stopped due to the company deciding that the data didn't look good. So that one's not going forward. And then Align, which is atrasentan. So you can see that all of these drugs, MOA stands for mechanism of action, they all act in slightly different ways. And I think this is really exciting for patients with IgA nephropathy because the more tools your doctors can have in the toolbox is better for you as patients, because if you don't do well with one drug, maybe there's something else we can use, or maybe we can combine therapies. So with that, I'm just going to end with you or your loved ones may be a good fit for one or more of these new therapies. Talk to your doctors or seek out an RKD specialist to talk more about this. and learn about clinical trials, because that's really how we're going to get more drugs out there, is if patients enroll in clinical trials. And NephCure is a huge partner for clinical trials. This is actually taken from their website. You can go and search your location in the box. Here's the website for those who are interested, and you can filter based on what trials are actively recruiting for your particular disease, and see if you might be eligible for a trial and that fits you. So with that, I'm happy to take any questions, and thank you guys so much for spending part of your afternoon with me. How are we doing with time?
We have about 5 minutes.
Okay.
But I want to give Courtney Walker here a chance to say hello and field any questions from you. She's one of our patient representatives. I'd like her to share her story and then take a question.
Hi. Okay. Good afternoon, kidney warriors and care partners. My name is Courtney Walker, and I was diagnosed with IgA nephropathy by biopsy in 2017. And when I was diagnosed, I was at eGFR 37. I also had 3 bowel resections and Crohn's disease prior to being diagnosed with IgAN. So your hit 1, 2, 3, 4, I'm very paying a lot of attention to, because I'd rather the gut catch these proteins than having it go through my kidney and my glomeruli.
I know, it's really hard to say glomeruli, yeah.
I used to say
Glom. I just say glom. It's easier.
Yeah. Or flow filter.
Yeah.
Right?
Mm-hmm.
So, yeah, I'm very interested in that to help keep my disease. After I received the diagnosis, I ended up going to the University of Kansas Medical System and being referred towards the transplant side. And my nephrologist and I sort of decided that with all the variables, and I started a mission to find a donor. And that was a social media campaign and asking friends of friends, people I didn't even know, to share my story through a website. And I was very fortunate to have my kidney transplant on August 22nd, 2023. And it's an interesting cocktail with the transplant meds, but overall everything is going well and feeling better. And I just am hoping some of these things that you brought up today will help, especially people with IgAN, not ever have to have that second transplant, with lifestyle choices and management and having a close relationship with your care team. So, yes. And then if you read her biography on page 37, she's amazing. You got Teacher of the Year 2018, 19, and 20 at the Feingold, Northwestern Feingold glomerular nephritis program.
Mm-hmm.
Yeah. So she got Teacher of the Year 3 times.
Yeah. Thank you.
Yeah, I think we have a valuable resource. So who has a question first?
We answered all. Yes.
Yeah, but I have too many questions.
I know.
I can pick one.
Mm-hmm. Start with one.
Yeah, I mean, I will start. With what I not the most stressful, but just because I'm curious. At the beginning, you were showing that basically the IgA looks like having this kidney bombarded by this kind of IgA plus some other kind of protein. So basically, is this that is damaging the kidney, right? But I don't understand, because it seems that when you have a transplant, the IgA can stop or can come back. But so, is the kidney responsible of these kind of things, or is the kidney just passive there and is bombarded? Because if it's passive, then it's bombarded. It doesn't matter if you change kidney; it will be bombarded anyway. But looks like the things doesn't.
Wow, to give me the hardest question to start with. So that's a very good question. And the answer is I don't know that we totally understand. There are patients, when you get a kidney transplant, it's pretty common, and you could probably attest to this, to get more kidney biopsies of your transplant routinely to see how your transplant's working. And some patients who have IgAN, when you look at the transplanted kidney, they do see IgA deposits showing up. What's rare is that those deposits actually lead to kidney failure and that your second kidney fails due to the deposits. Now, there's a number of reasons that people's kidney transplant may fail, but the IgA nephropathy sort of recurring in the transplant and that leading to that transplanted kidney failing is not very common. Whether it's a patient issue or a kidney issue is a good one. I think that I would probably suggest that there's something innately within the person that makes them more susceptible, and that something comes along and triggers, whether there's an infection or something else that triggers that particular person to develop IgA nephropathy. Now, you're right, we can switch out the kidney, get a new kidney, put you on a lot of immunosuppressive medications. So after transplant, patients are often on things like mycophenolate, tacrolimus, maybe a little bit of prednisone, so their body doesn't, to reject, so their body doesn't reject the transplant. And perhaps that's why you're on so much immunosuppression after a kidney transplant that you're not reactivating or you're not having the IgA come back in most patients. Even though you might see the deposits, it's not really leading to full-blown IgA nephropathy. But there are some patients who do get recurrence, and I think that's a really interesting thing that we need to understand better. I had a patient who's in her 20s. Her IgA, when it presented, it was really rapid. She ended up on kidney failure very quickly. She got a kidney transplant, and it came back really quickly again, and we don't really know what's going on with her in particular compared to all my other IgA nephropathy patients that don't seem to have this happen to them. Why is she having this issue? And I think, we can learn a lot from studying people like this, and I would encourage everyone to enroll in some of these also disease registries like CureGN. If you've had a biopsy within the last 5 years, these disease registries that we have, you can go to curegn.org and see if there's a site near you. It allows us to study these types of things where we get blood and urine from tons. We have over probably, I would say something like 800 patients with IgA nephropathy in CureGN, and then we can start answering some of these difficult questions, especially the longer they're in the study, and some of them get kidney transplants. So I don't know that I actually answered your question because I don't really know the answer, but I think it is something we need to study more, and I don't want people to feel like if they get a kidney transplant, there's a really high risk of their kidney being lost due to IgA nephropathy coming back. It's actually not very common. Unfortunately, we just don't know who's going to be that unlucky person where it does come back.
A lot of times I do still follow the IgA diet or eat to your labs. Even though I have a new kidney, I'd like it to stay in as long as possible. So I do still eat to labs. How about anybody else?
Big one question from Lauren, and then I'm sure we're going to try it.
So I had a kidney transplant last year, and it's just my IgA is recurring. Is I tested, am I able to do any of the piloting? Because I was campus, so a lot of
Yeah.
you're not allowed to do any stuff.
Yeah, it's there's two problems with clinical trials. One is that there's not enough trials for pediatric populations, and the other is that they don't typically enroll patients with kidney transplants. So it's super frustrating because how are we going to answer these questions if we don't know? What I can tell you is, and maybe you can speak to this, a lot of kidney transplant doctors are getting sort of off-label access to some of these medications that are FDA approved to try to see if they help. And so I would definitely talk to your transplant doctor, and if they aren't familiar with them, I would seek out, maybe a glomerular disease specialist in your area that might be able to talk to your transplant doctor.
Talking about the diabetic ones, I'm on the sartan right now, just as a start.
Yeah.
But if it escalates or doesn't help, then we're going to try it.
SGLT2 inhibitor? Yeah. Okay. We'll be thinking of you.
We said two things. One is we have a little break here before our next session down the main row. Dr. Wadhwani's around. He's going to some refreshing community. Second, I just want to thank our friends who sponsored this session. I found very informative.
Yes.
And that's our friends from Novartis who are in the back of the hall.
Thank you.
Thank you. Thank you. Thank you.